I think we get started. So I'm talking today on hip dysplasia, which is obviously a pretty big topic, so I've sort of tried to split it up amongst our age groups, and I'll just give a pretty brief overview of the condition itself and how it develops, as well as the investigation and treatment options. So as I mentioned, we'll talk about the definition and incidence of hip dysplasia and a bit about the anatomy, both the normal anatomical development of the hip as well as the pathological development. A bit about the natural history, and then we'll sort of split the investigation and treatment up into young children, adolescents and adults. So hip dysplasia is basically a disorder of abnormal development of the hip. And this sort of happens right from the start, from a young age, and even can occur in utero, and it's caused by an abnormality, normally with some laxity and causing a subluxation or dislocation of the femoral head. And this can be associated with either genetic or mechanical factors, and this leads to abnormal development and dysplasia of the hip. And there's a couple of terms that are used now. The term developmental dysplasia of the hip is the accepted term, and this is really interchangeable with congenital dislocation of the hip, which is a term which is sort of no longer used. Classically in the literature, it's described as an incidence of about 1 in 1,000 people. Now, Barlow did a study, obviously Barlow of the Barlow test, which we'll go into a bit later, and he showed that about 1 in 60 newborns had a degree of instability of the hip. 60% of these became stable by 1 week, and 88% of them were stable by 2 months. And sort of extrapolating that, the remaining 12% would have it as around about 1 in 500 the incidence. So incidence probably somewhere between 1 in 500 and 1 in 1,000. Females have a predominance over males, and one theory that's been put forward for this is that females may be more receptive to the hormone relaxin, and this can cause laxity during the birthing process and subluxation of the hips. Left hips are more common than right, and it's seen as bilateral at about 20%. Looking at the risk factors, female sex that I just mentioned with a 6-to-1 predominance over males. Firstborn, this can be due to prolonged labour times, breech delivery, family history of hip dysplasia, as well as oligohydramnios. We talk about the anatomy and what the sort of normal growth and development of the hip. Now, it's something that requires a genetic blueprint for how the hip's going to be developed, as well as an influence, a sort of mechanical influence on how the hip is seated while it's developing. So it requires that genetic blueprint to develop the hip properly, as well as having a well-centered femoral head in the acetabulum to allow the acetabulum to develop. If we remember the embryology, the femoral head and the acetabulum develop from the same mesenchymal cells, which develop a cleft and begin separating at around the 7th week in utero. And around about the 11th week, the hip joint itself is fully formed. So any time from the 11th week onwards, the hip can theoretically sublux or dislocate, and this can cause problems with the development. During the time in utero, initially the hip joint itself is deep, but that sort of the acetabulum shallows out closer to birth, and it's thought that this is to provide a more lax joint to allow the birth of the child to progress with less obstruction. At birth, the femoral head has a single chondroepiphysis, and the proximal femoral and femoral head ossification centers appear around about the 4th to 7th month of life. So the normal development of the acetabulum relies on the presence of the spherical femoral head in the acetabulum to allow that to develop around that, and also it needs that genetic factors to have the normal growth of the acetabular and the triradiate cartilages. So normally, in a normal hip as such, there's a good fit between the femoral head and the acetabulum. And if there's a shallow acetabulum or any sort of capsular laxity or laxity in the joint there, this can lead to a subluxation or a dislocation of the femoral head, and then the subsequent development of the acetabulum is going to be abnormal. And it can lead to defective components both in the femur, the acetabulum, and in the capsule itself. We can classify hip dysplasia in the newborn as either being what's called typical dysplasia, in that the child is otherwise normal but just has a dysplastic hip, or it can be associated with other severe malformations. And this is probably more going to be an issue with that genetic blueprint of how the hip's designed to develop. The natural history overall is quite variable, and again, it goes back to the fact that because the child is constantly developing, if things change along that spectrum when they're developing, they can have a variable outcome. In a neonate that has a dysplastic acetabulum, but who doesn't have any significant laxity or subluxation or dislocation, they are likely to progress to having normal hips. It's more the instability that then becomes a problem, because if we have the subluxation or dislocation, then you're more likely to go on to dysplasia, and then you have the sequelae of that. After about 6 months of life, if the hips aren't or are becoming dysplastic and there's the hip joint's not properly end-located, it's unlikely to spontaneously resolve. So from there, it requires more aggressive treatment, because along that time, as the child gets older and older, their chance for remodeling or their potential for remodeling decreases. And then once you get into adolescents and adults, you start having problems associated with their gait and range of motion from having an abnormal hip joint, as well as the muscles around the hip don't have the sort of mechanical advantage they're designed to have, and you have some weakness there. And then it's thought that there's an increased rate of degenerative joint disease going on into adulthood with hip dysplasia, although it's very difficult to ever prove this, because we don't know how many people out there have hip dysplasia that never develop degenerative disease, because it tends to be the only people we see are those that are symptomatic. Looking at the presentation, so again, as I mentioned at the start, this all differs quite a bit depending on the age. So when we're looking at the very young, the mainstay of diagnosis is on physical examination, which is why all newborns in Australia are screened by physical examination to see if they have potential hip dysplasia. And the key is provocative tests, the Barlow and Ortolani test, to see if the hips are either dislocatable or reducible, and also a Gagliardi test to see if there's a significant obvious leg length discrepancy to start with. Clicking hips as such are non-specific, and it's really something that can lead us to think that there's an issue, but it's having a hip click on movement is not necessarily something that is associated strongly with dysplasia. As I mentioned, newborn screening examination is the key to picking this up. There's been discussion about ultrasound as a screening tool. It's shown that this is probably not a cost-effective way to do things, but can be used to screen at-risk babies. So if there's a strong family history, breech delivery, things like that might make us worry about hip dysplasia. As the child gets older, as they get above 3 months, the Barlow and Ortolani tests can become, they're really positive, and they can be non-diagnostic due to soft tissue issues, contractures around the hip that means that you no longer get the positive tests there. The key things there are starting to get a limitation in range of motion, particularly abduction of the hip, and assuming it's not a bilateral problem, decreased symmetry either with the range of motion. Often people talk about the groin creases being asymmetrical and having an obvious leg length discrepancy. Once you're getting over a year, it tends to be something that's picked up when the child starts walking. They can have a pelvic obliquity or pelvic tilt and a Trendelenburg gait, or they may be toe walking on one side if they have a shorter leg on that side due to a dislocation of the hip. Then they may walk on their toe to try and compensate for that leg length discrepancy. As a reminder of the first the Barlow test, where the newborn has their hip flexed and brought into adduction, and then some sort of downwards pressure is provided on that, which can, in a positive test, results in a sensation of the hip being dislocated posteriorly. And then this is usually followed by the Ortolani test, where by putting the fingers on the greater trochanter and abducting the hip still in that flexed position, you can feel the hip click back into joint. And here's an example of a Galeazzi test examining for a leg length discrepancy. When we're classifying these in the newborn, there's three broad types. There's the hip that's subluxatable, so that the femoral head can be partially displaced out of the acetabulum, and that's the Barlow suggestive. The Barlow test is suggestive of that, or a frankly dislocatable hip where the Barlow test is strongly positive. And then the third category is the dislocated hip, and that can either be reducible in that they have a positive Ortolani test, especially early in the piece, but when it becomes irreducible, their Ortolani test is going to be negative. So if we have concerns, then we need to go on and do some radiological investigations. Now, in the newborn and the very young, ultrasound is the key tool, because, as you remember, the ossification of the femoral head doesn't occur until sort of 4 to 7 months of life, so you need to do an ultrasound to try and confirm that diagnosis. So that allows a good view of the bony anatomy of the acetabulum, also seeing the femoral head and labrum, as well as the hip capsule. So a patient that has a clicky hip and a normal ultrasound is likely to go on to normal acetabular development. The other use of ultrasound is as well as initial diagnosis, for monitoring along the way. If they're managed, for example, in a Pavlik harness, which we're going to talk about, it allows for follow-ups to see how that is going. As I mentioned briefly before, screening, some studies have been done to look at the cost effectiveness of screening all children with ultrasound, and it's thought that that's not cost effective. So it's more if there's a newborn examination that is suggestive, then children should get an ultrasound, or if there's a strong family history or other at-risk, if they fall into other at-risk categories where we may want to screen them. X-ray becomes the primary modality after we get the femoral head ossification around 4 to 6 months, and that can look for evidence of dysplasia and of dislocation of the hip joint. CT and MRI initially in the very young are used for confirming reduction post being put in, for example, into a hip spiker. Initially, CT was really the modality of choice for this. As you can imagine, the downside of that is the large amount of radiation to a newborn. There's been some studies done at the Royal Children's Hospital here where they looked at MRI, and MRI is very good because it doesn't just show us the bony anatomy, it shows all the anatomy around the hip, and you do get a good view of the reduction of the hip joint, and that's what we use preferentially here as well. Here's an example of an ultrasound of normal hip. And the key things that we look at, so the femoral head is here, and the ilium comes along here, and a line down through the ilium should bisect the femoral head. And then we have two angles that we look at. The alpha angle here, which I believe should be above 50 degrees, and the beta angle, which is one here in front, which should be below 60. And then, so that's a normal ultrasound of a hip joint, and then we can see subsequently here on an abnormal ultrasound where that line is no longer bisecting through the femoral head, the alpha angle is reduced and the beta angle is increased. So that's a positive ultrasound for a subluxation or a dislocation of the hip. Looking at plain film x-rays, there's a couple of key things we look at on that. So one is if we draw a couple of lines, Hilgenreiner's line, which bisects through the triradiate cartilage on both sides, and Perkins' line, which should come through the middle of the acetabulum. Now, in a normal hip, the ossification center should sit sort of in that medial inferior quadrant down here, such as on the right hip shown here. And when it's abnormal, it tends to be displaced away laterally and superiorly. The other thing we can look at is Shenton's line, which is intact in a normal hip and is broken in an abnormal hip. Here's another example of that, in this case with bilateral dislocation of the hips. And again, a view of Shenton's line with a more subtle presentation. If we're looking again at those quadrants, the right side here doesn't look like it's sitting out too laterally, but Shenton's line is broken. And the other thing that's we often see in these dysplastic hips at this age is the femoral head ossification center is smaller on that side than it is on the left-hand side. And again, that goes back to that idea of, for the hips to develop normally, they need to be in that normal environment. So treatment in young children is based on getting a concentric reduction of the hip to allow it to develop properly and to prevent any further degeneration. And as we go further along chronologically, it becomes more difficult to treat these because the hip becomes more difficult to reduce. The mainstay early is non-operative treatment and bracing in a Pavlik harness, and if there's problems with that, if the screening or the follow-up ultrasounds that are done in the Pavlik are showing that the hip's not reduced, then they may need to go on to a formal closed reduction under an anaesthetic and a spica casting. As far as operative intervention goes, that can be, at all stages you need to have an open reduction of the hip joint, and you may need to do osteotomies around the hip on either side if you can't get or maintain a good reduction. Here's a treatment algorithm, and again, the key thing on the left-hand side, which needs to be reinforced, is that age at presentation is really the key factor that guides our treatment. In the very young, we're looking at putting them into a Pavlik harness and then seeing if they're concentrically reduced. If they are, we can continue on with that treatment. The older they get, the Pavlik harness is not going to be suitable, and they likely need to have a formal closed reduction and to be put into a spica, and then to see if that is reduced. And as I said, our investigation of choice for that is an MRI scan. And if that's not successful, or if the patient is much older, you're likely to require an open reduction and then to be put into a spica as well. And generally the hip spicas are on for around about 12 weeks and are often changed after about 6 weeks. After that period, some people will go on to put them in an abduction brace, and then further follow-up is done down the track to see if the acetabulum is remodeling. If it is, that's obviously good. If not, they may need further procedures to have an osteotomy done. And key thing is they need to be monitored until skeletal maturity to ensure that their hip joint is developing normally. Here's Professor Pavlik and his harness there on the left, and a modern interpretation of this. So the key thing is that there's straps both anteriorly and posteriorly. The anterior straps allow for the flexion of the hip, and the posterior straps the abduction, and put into that sort of frog position to allow the hip or the femoral head to sit in the acetabulum. And an example of a spiker cast. When an open reduction is done, it's generally through a medial approach, and the key thing is really, once getting down to the hip joint, to having a tenotomy and lengthening of the psoas tendon, a medial capsulotomy, and then the hip joint can be directly reduced, and often anything that can be cleared out of the way, such as the labrum or the transverse acetabular ligament that may be blocking the reduction there. Moving on to adolescents, it's rare to make a diagnosis without them being symptomatic, and the main symptoms are those of pain. This can be either a fatiguing pain on exertion, which is due to the shortened hip abductors, or they can have just a generalized ache in the hip. The other things, they can develop a limp and have a restricted range of motion. On examination of their hip, the key things that we're looking for is looking at their gait and seeing what their range of motion and leg length's like. Screening their lumbar spine to see if there's any related issues there. And a lot of these things need to be considered with having an osteotomy in mind, especially looking at the range of motion, what range of motion they have on the normal versus the abnormal side. In an adolescent, our investigations are X-ray and potentially CT. X-ray will confirm the diagnosis, and key things we look at there are the acetabular index and the centre edge angle, which I'll mention in a second. CT can be useful because dysplasia can occur, effectively occurs in 3 dimensions. Doing a CT gives us more of a 3D representation of this, especially if we're looking at doing an osteotomy, having an understanding of the anatomy that's present. So looking at the centre edge angle, if we take a line between the centre of both of the femoral heads, and we draw a line that's perpendicular to that, and then a line that goes from the centre of that femoral head to the edge of the acetabulum. Now, a normal hip, that will be 15 degrees or above, and as a hip is more dysplastic, that angle will be less, and there will be more uncovering of the femoral head laterally on an X-ray. Here's an example of a reduced centre edge angle, and you can see that the femoral head laterally has less coverage from the acetabulum. Often as well, we do a false profile X-ray to look at the uncovering of the femoral head anteriorly. Again, dysplasia can occur in 3 dimensions, so doing just a plain AP film often doesn't tell the complete story. So having a false profile, which is taken obliquely, again, we can see a reduced centre edge angle anteriorly and having anterior uncovering of the femoral head. The acetabular index, again looking at a line taken through the triradiate cartilage, a normal hip, as we can see on the right, has a centre edge angle of below or less than 25, an acetabular index. So from the triradiate cartilage to the edge of the acetabulum, the normal acetabular index is less than 25 degrees. And as we can see on the dysplastic hip on the left here, that has a 40-degree acetabular index. So adolescent management, I guess the first point here is one that is controversial and is debated a lot, that they should only be treated if symptomatic. Again, this goes down to the fact that our understanding of the natural history is that these patients probably go on to have earlier degenerative joint disease, but that's not strongly shown at this stage. So realistically, though, we're probably only going to see these patients if they are symptomatic. The non-operative management is similar to that that we undertake for patients with osteoarthritis. Activity modification, so if certain things are causing them pain, trying to avoid that, analgesia, and weight loss. The hip joint is a difficult joint to reduce demand on, though. And then operative management, the three mainstays of operative management are osteotomy to try and preserve the hip joint and try and develop a more normal hip joint, or create a more normal hip joint, arthrodesis, and arthroplasty, although naturally a hip preserving surgery is preferred in the adolescent age group. So talking about osteotomies, the general principles for osteotomies around the hip in dysplasia in adolescents are that you should obviously operate on the side that is more effective initially, but the patient may need both sides operated on. And the key is to try and realign the joint to provide better coverage of the femoral head with using normal or undamaged articular cartilage, equalizing their leg lengths, and also correcting any femoral malrotation that may be present. And then you need to optimize their abductor function, and this sometimes needs a abductor or a trochanteric transfer to try and provide that. And you should, again, as far as sort of any sort of operations on any joints go, try and restore the natural weight-bearing axis. And we need to have an understanding of future operations that may need to be carried out and not do anything that can compromise those. There's multiple different osteotomies around the hip that have been described, and basically the key with most of these is effectively cutting out that acetabulum and tilting it and providing better coverage of the femoral head without decreasing the acetabular volume. The Bernese or the periacetabular osteotomy is the one that is probably described or researched the most in the literature. And we'll talk about the Chiari osteotomy later. That's more of a salvage procedure rather than a true preservation. So here's an example of a Bernese osteotomy where, again, that whole piece of bone containing the acetabulum is cut out and is tilted and held with some screws to keep that in place. And the idea is, as you can see here, if you imagine what our center edge angle is and the uncovering of the femoral head here laterally, and then providing more coverage to that femoral head. And you can probably appreciate as well, if this hip was, or if this leg was slightly shorter, this has been given some length on that side, that leg. Here's some post-operative radiographs showing that procedure. And this is an example of another osteotomy that wasn't shown previously, which is called the Degar osteotomy, where a piece of a wedge of the iliac crest is taken. The osteotomy is made superior to the acetabulum, and that is sort of opened up and has the wedge that we've removed from the iliac crest inserted in there. This can, though, because we're not moving the whole acetabulum, it can decrease the volume of the acetabulum. This is a picture of Richmond defender Calvin Moore, who's had some publicised hip problems, and is, interestingly enough, I read the other week that he's had a periacetabular osteotomy because he has hip dysplasia. Recently came back to play for Richmond, and that coincided with them losing to Greater Western Sydney. Moving on to the presentation amongst adults. It's similar to presentation with adolescents, except we often introduce degeneration in this age group. So this is again often the first presentation that the patient is shown to have some degeneration in their hip joint, and we find that their hip joint itself looks dysplastic. As far as the treatment goes, the key thing really is assessing the degree of degenerative joint disease, because this can guide what our treatment is going to be. If a patient has a severely degenerate joint, there's no point trying to save that joint, and arthroplasty is likely to be their best option. So as far as, again, non-operative management is symptomatic or supportive treatment. As far as operative management, again, we look at pelvic osteotomies. All the osteotomies that can be done in adolescents can be again done there to try and reconstruct the acetabulum. There's also salvage osteotomies that can be done to try and, often this is done as a last resort to try and save the hip joint, but is also done with an eye on the future with a patient needing an arthroplasty and building up some of the bone stock around the acetabulum. And then patients can also need femoral osteotomies if a pelvic osteotomy alone is insufficient, or if the primary site of dysplasia is at the femur. And then arthroplasty is often an option used in these patients. This is an example of another osteotomy. This is a shelf osteotomy, which is a salvage procedure whereby literally a shelf of bone taken from the outer table of the pelvis is inserted superior to the hip joint to literally create a shelf there to provide some coverage to the femoral head. And as you can imagine, this doesn't have normal articular cartilage, so it relies on some scarring and fibrocartilage formation, but it does provide a bigger stock of bone there if we're going to look at going on to do an arthroplasty. Similarly, a Chiari osteotomy where the hip joint itself is medialized and we get coverage over the femoral head by the ilium here. Again, it doesn't have normal articular cartilage over that and relies on development of fibrocartilage. And if one of if a femoral dysplasia is one of the main things with the dysplasia around the hip, they may need a femoral osteotomy. As you can see here, the hip on the left is quite valgus, and by doing an osteotomy to make that a more varus neck, that's an attempt to try and correct that. And you probably appreciate there's less uncovering of the femoral head laterally on that post-operative x-ray on the right. Often this is done in combination with a pelvic osteotomy, and sometimes by making things more varus, it can reduce the tension in the abductors, and sometimes an abductor transfer is needed. This is from a review article looking at the Bernese or the periacetabular osteotomy in adult patients and the outcomes of that. And I guess the key things to look at here is the patients are generally quite young. Looking at patients with advanced arthritis, through these various studies there are a differing amount of these. Now, some people would say advanced arthritis is probably a contraindication to doing a periacetabular or a Bernese osteotomy rather than doing something like a shelf or a Chiari, but some of these studies do have a large percentage, up to 21%, that had grade 3 changes there. The clinical results are all relatively reasonable for that, but I guess the other thing to look at is the conversion to total hip replacement, which sort of goes between 5% and 17%. In a lot of these patients, they will eventually need a total hip replacement regardless of what is done, and a lot of that comes down to the fact that they're likely to have some degeneration. This is only looking at the patients with grade 3 changes, but they're likely to have some changes, degenerative changes there. And because of their young age and the fact that they've been although effectively they are young, these patients have been living with dysplastic hips for a number of years. They have had a lot of abnormal force going through that hip and are likely to still have issues with degeneration. If we're looking onto arthroplasty, and often with arthroplasty we look at the Crow classification of dysplastic hips, or especially to do with the subluxation or dislocation of the hips, and these are classified from 1 through to 4, depending on the amount of displacement, less than 50%, 50 to 75, up to 100, or greater than 100%. And looking at some examples of that, so this is a patient who on the left there has a Crow 1, so has less than 50% displacement of the hip, and that's generally taken from a line that goes through the teardrops. If we draw a straight line through that, and then looking at the displacement from that. And then as we go up, the Crow 2 here, so up to 75% displacement, and you can see the development of some sclerosis and degenerative joint disease on that side. A Crow 3, and you can see the severely dysplastic head here, and the teardrop of the acetabulum is probably right down here, and they've developed more of a pseudoacetabulum higher up. And then looking at a patient with bilateral Crow 4 dislocation with greater than 100% dislocation in that femoral head. And these can be key as far as looking at what our treatment options are for these patients and having an understanding of what the best treatments are. This is again for a review article looking at arthroplasty options in adult dysplasia, and they've sort of looked at a lot of studies and looking at what is the best thing to do. I guess the key things to take out of this are looking at the type really dictates the treatment, and it's shown in multiple studies that using an uncemented acetabular component is key with this, with most studies looking at a cemented acetabular component had failure of that. Looking at the femoral side, Crow 1 to 3, effectively you can use a surgeon's choice as far as a cemented or an uncemented component, and again looking at the approach is really can be done either anterolaterally or posterolaterally as per the surgeon's preference. Once there is significant displacement of the hip, if we're looking at getting the hip joint or recreating the acetabulum in its true, effectively normal position, this will often lead to quite a lengthening of the limb, and there's especially concerns there with causing damage to the sciatic nerve. So often these patients will need a femoral osteotomy and a shortening of their femur as well. And often that's associated with putting in a long uncemented stem. I guess the other option to discuss, which is mentioned here, especially with the Crow 3, is rather than trying to bring the hip down, giving them a high hip-centered hip, which I'll show in a second. So examples, the Crow 1 patient, a hip replacement, pretty much as per what we do for a more normal degenerative hip joint. Once there's some more displacement, this is bilateral total hip replacements, which have been done here in association with putting a bone graft above the acetabulum, which is often taken from the resected femoral head, as well as there's been a trochanteric advancement osteotomy. Here's an example of what I was talking about of a high hip-centered hip. So rather than trying to restore a so-called normal acetabular position down lower, surgeons opted for having a hip center higher there. And this obviously decreases the need for doing things like femoral osteotomies and having the concerns related to that. And then here is a Crow 4 patient who's had their acetabulum restored to a normal position. As you can see, a very small acetabular component, which is often the case in these because of the true acetabulum is not developed normally, and there's been a shortening of the femur there through a femoral osteotomy. As far as the results go with these, I've found that it's sort of not very well studied in the literature. There's been a lot of research on acetabular components and looking at either restoration of the normal acetabular position versus the type of component that's used. As I mentioned, a lot of the studies looking at cemented acetabular components showed a high failure rate amongst those, whereas a much lower failure rate amongst uncemented components. There's no real good outcomes data looking at the various treatment options amongst these. This is again from the similar review article looking at the results of the acetabular reconstruction, and I put this in just to show the revision rates looking at the cemented acetabular components. As you can see, in the first lot here and the third lot here were all cemented components, and when we compare that to cementless components, either with or without acetabular augmentation, then the need for revision of those or any failure of those components is in fact much lower. I guess in summary, looking at hip dysplasia, it's a complex condition that can present at a number of age groups along the way, and our investigation and treatment depends on what age category they're in. In the very young, the newborns, the key is really to relocate the hips to try and get normal acetabular or normal hip joint development. As the child gets older and they have established dysplasia, we're looking at trying to preserve that hip joint. And as they are getting older, and into adulthood, we may be able to preserve the hip joint, but it may be a case of salvage or needing to replace that joint.